Thank you, Bill. And on my disclosure slide, I wish I had some. My topic is threshold targets and reconciling the results of the SPRINT, the ACCORD, and the HOPE-3 trials. You've already heard discussion regarding the HOPE-3 trial, and the trials provide somewhat different results, but the issue becomes one of can these be in fact reconciled? So that what I will do will be to compare the results of SPRINT, the ACCORD trial, and HOPE-3. We'll compare the objectives and designs of these three trials, and then examine the results of the three trials for consistency in the context of both their objectives and their designs, and then hopefully draw some conclusions on the implications of the SPRINT results, I think, which in the context of both of the ACCORD and HOPE-3 trials. First, consider the ACCORD trial. This study was published with Dr. Cushman as the first author in 2010. And it showed that there was a non-significant, a non-significant 12% reduction in the primary outcome in treating diabetic patients to a systolic blood pressure of 120 compared to one treated to the systolic blood pressure target of less than 140, as you know. The reduction, the 12% reduction was not significant. There was a significant reduction in stroke, about a 41% reduction in stroke that was significant. When we come to the SPRINT results, SPRINT again compared, in this case, non-diabetic patients to the same systolic blood pressure targets, 120 versus 140. And in contrast to ACCORD, in fact, found a dramatic 25% reduction in the primary outcome, and these are all hard outcomes, that was highly statistically significant. And not only that, also showed a 27% reduction in even all-cause mortality, including a 43% reduction in cardiovascular mortality. And then you've seen the results of HOPE-3 already presented, and it again, in this case, a very large trial, very well done, showed a non-significant reduction of blood pressure in the patient population treated with low doses of two drugs in a very large trial, 14,000 patients. Let's start first with the SPRINT and ACCORD trials. There are both treated compared treatment to a systolic of 120 versus 140. If you look at the designs of the trial, SPRINT was a very straightforward trial. It only looked at the comparison of you treat one group of patients to 120, the other to 140, and then count up the number of cardiovascular events. Whereas the ACCORD trial, in addition to the two blood pressure targets, also had two different diabetic targets, as well as two different lipid treatment comparisons incorporated into that factorial design. In addition, the trial SPRINT was about twice the size of ACCORD, and also when we look at the design of the trial and the expected event rate in SPRINT, it was right on we predicted about a 2% event rate per year in the control arm of SPRINT, and we achieved about a 2% event rate, whereas in ACCORD, the ACCORD trial predicted about a 2%, again 2% event rate, but only received a half of the event rate that was anticipated. So the SPRINT was twice as large, and had an event rate that was right on in terms of what was expected, whereas the Accord trial was half the size and had half the events that it anticipated. So therefore, the Accord trial had substantially less power to show a difference between the two comparison groups. Of note, with the publication of SPRINT, there was an editorial that was actually published, as shown here, that looked at compared the results of Accord and SPRINT, and also looked at the if you combine the results of the two trials, and as you can see, there's very little difference in terms of if you look at the hazard ratio and the confidence intervals, there's very little difference in the results. Whether you look at non-fatal MI, stroke, heart failure, or the primary outcome as defined in each trial, there was very little difference in the results of these two trials. So that the major difference was the fact that these trials, whether or not they had the ability to, their sensitivity in terms of detecting differences between the two studies, and the much greater power of SPRINT to look at its results. What's also reassuring in comparing the two trials, but much less, but not necessarily confirmatory, is the fact that if you looked at in the Accord trial, if you looked at the control, of those randomized to the standard diabetic control arm, at the two blood pressure targets, you see that the hazard ratio now, the hazard ratio for the primary outcome is very similar to what was seen within SPRINT, at about a 26% reduction in the primary outcome. That was the upper confidence limit is 1.0, but certainly well within again, the confidence intervals clearly overlap. Now, what about HOPE-3? HOPE-3 has been well described here. Again, very large trial. It looked at the placebo-controlled trial, great quality control, and it compared treatment of the modest to moderate dose of candesartan and a much lower dose and not well tested, 12.5 milligrams of hydrochlorothiazide. The difference between SPRINT and HOPE is that in SPRINT, used an individual patient approach. Patient comes in the office, and the decision has to be made: do you treat to one target versus another? Do you treat to 120 or 140? Over 90%. It was certainly a high-risk patient population. 91% of the participants were already on antihypertensive therapy and received about there was a 15 millimeter of mercury reduction in blood pressure in those treated to less than 120 compared to less than 120. Whereas the HOPE-3 used a population-based study approach, where in fact you treat a population with a drug or not. And then it had a much lower risk patient population, and in fact only 37% of the participants in HOPE were actually had the diagnosis of hypertension. The blood pressure reduction was a lot less, only 6 millimeters of mercury as opposed to 15 millimeters of mercury. Therefore, where SPRINT tested two different intensities of intervention in a population that was most likely to respond to treatment and to benefit from that treatment. The HOPE-3, in fact, it became harder to show a benefit of treatment in a lower risk population, especially if the intervention had only modest efficacy. And in fact, if you look at the treatment, if you look at the lower tertile of patients in HOPE-3, as shown in the previous slide, the achieved mean baseline blood pressure was systolic of 122, which essentially approaches the treatment target in the intensive arm of SPRINT. And as we know, it's kind of difficult as you begin to approach zero. The challenge in showing benefit of adding antihypertensive medications to the regimen becomes certainly more challenging. A few more points about the SPRINT trial, because one of the questions that's also asked is, because SPRINT could enroll patients down to as low as 130 millimeters of mercury, the question, does this mean that SPRINT would suggest that that should be the starting systolic blood pressure to initiate therapy? Shown here, about a third of the participants in SPRINT had a baseline systolic blood pressure of less than 132. And they did well. In contrast to HOPE-3, those in that lower tertile actually did, as shown here, certainly did no worse. The big question, though, the difference, though, is in SPRINT, again, 90%, there were very few patients in that less than 132 that were untreated. Most of the patients were treated in SPRINT. So that you cannot use the SPRINT. SPRINT cannot inform the decision in terms of the treatment threshold to initiate treatment. I want to show this slide because of the recent ACP AAFP suggestion that in patients over age 60 should be treated to initiate treatment and have a target of 150. As shown here, these were SPRINT participants. This was slide has not been updated. This was actually published in JAMA about a year ago. And it shows that this is in patients over age 75. And in fact, whereas the number needed to treat in the entire cohort in SPRINT to reduce the primary outcome was 61. In fact, the number needed to treat in those over age 75 to achieve reduction in primary outcome is only 28 patients. For all-cause mortality, rather than having a number needed to treat of 90, in fact, it was 41. And so that, if anything, even greater benefit is seen in treating patients over age 75 than in the overall cohort. So in summary, SPRINT reported a 25% reduction in its primary cardiovascular outcome and 27% reduction in total mortality with treatment to a systolic blood pressure target of less than 120 compared to one treated to less than 140 in a population with elevated blood pressure and high cardiovascular risk. Accord compared similar systolic blood pressure targets as in SPRINT, but in a factorial design with much more limited statistical power, and reported a non-significant 12% reduction in the primary cardiovascular outcome, though its 95% confidence intervals showed substantial overlap with the SPRINT results, including up to a 27% in CVD reduction. As noted, the sample size is only half that in SPRINT, and the observed event rate was also only half of that expected by its design. HOPE-3 was designed to assess the effect of low-intensity lowering of blood pressure and cholesterol in an intermediate risk population, and not designed to assess the effect of treating two different blood pressure targets. The lack of benefit in HOPE-3 is likely explained by certainly the lower intensity of treatment, as well as lower population risk, and as well as a lower indication for antihypertensive drug treatment. With that, I'll conclude. Thank you.